Okay, so when you guys intubate somebody and you're in the scene of the chaos and all that stuff is going on, you're just gonna put air in the cuff, and we're not checking cuff pressure then. So the time when it comes to be checking cuff pressure is once you get your patient situated, get them on the vent, and you're doing your initial vent check and assessment. So that's when we're checking cuff pressure. Because people are like, we're doing this right in the middle of a code. No, intubate your patient. Just put air in the cuff. Make sure you don't hear it leaking, and then do this once your patient gets situated. So there's 3 different ways that you can measure cuff pressure. So it's very, very important to measure cuff pressure on your patient because we want to make sure that we're not having too much pressure in the cuff and it's going to erode into the tracheal wall. It does and will cause damage. I've seen it in Bronx, and you've seen the damage that's been caused. RTs out there are very lax at checking cuff pressure, and they like to go, oh, feels good. Cuff feels good, and they just see how they feel this. It feels like a little pillow of air, and they're like, oh, great, feels good. That's worthless. You might as well not even bother doing it. That doesn't tell you anything about how much air and pressure are on your patient's tracheal wall. So the first thing, sometimes this is used just by itself. This is called a cuffilator. Cufflator. Cuffilator. And what you can do with this is, once this has air and it's in your patient, you can take this and you put it onto the pilot balloon like this, and if it actually had air in it, it would register a pressure on the dial. And you want it to be in the green, which is between 20 and 30. You do not want your cuff pressure to be more than 30 as a general rule. If you needed to put more air in it, you would pump it up like this. And yeah, there we go. See? Let's put air in it. And then if I wanted to deflate it at the same time, then you could take the red and it lets air out. That red button lets air out. So that's how you can use this. I don't like the cuffilator on its own. I'm going to talk about you using it in conjunction with something else in a minute. Because if you use the cuffilator, you've basically said that every adult patient on mechanical ventilation needs 20 to 30 of air pressure. No matter what. Doesn't matter if it's 20, 22, 24, 26, 28, 30, whatever. As long as it's in the green, we're good. That's not really the best way to manage your patient's cuff, to give just a generalized statement like that. Because everybody in here could use a different cuff pressure. And the idea, just like we want to ventilate someone with the lowest possible pressure, the idea is to use the lowest possible pressure on your cuff so you don't cause damage to the tracheal wall. Some of it's inevitable, but you don't want to be responsible for it by having a cuff with too much air in it. So the second way is called the MLT. It's the minimal leak technique.
But I'm not a rapper.
You're not a rapper? The minimal leak technique is a way that we can make sure that our patient's cuff has the least amount of air possible in it while still sealing off and protecting the airway, which is the whole purpose of a cuff. So what you do in this situation, so this is in our patient, and we come over. So what you're going to do is take your stethoscope and listen over the trachea. And then you're going to remove air from the pilot balloon and ultimately the cuff. And you're going to hear a big gurgly leak. Now, if you think about it, we don't want to be doing that all the time because you'll learn that aspiration of secretions above the cuff is the number one. It's how people get ventilator-associated pneumonia and VAP, and we don't want that. So we're not talking about doing this every single time you go see your patient. It's basically should be done once your patient is intubated and put on the vent and settled in, and then only on a case-by-case needed basis going forward, and I'll tell you why as we finish. So put it in, so the tube's in, we take all the air out while we're listening, and then what you want to do is see how much air is in your syringe. So let's say it's 8 cc's. While you're still listening, put air back in the cuff and see and stop when you hear the leak go away. And it's hard to describe, but you'll know it when you hear it. You can hear the leak. It's a loud gurgling sound, and you'll know when it stops. So when it stops, see how much air is in your syringe. So let's say you had 8, now you have 4. Then you know it took about 4 cc's to occlude off the airway. Everybody with me so far? Then, pull the syringe back just a little tiny bit. The idea is so you just hear like a little squeak, I say, because you don't really want to get carried away with it. The idea by doing that is that you just use the least amount of pressure necessary to seal off the airway. So once you do that, now we know that it's a proper amount. And I already told you that we don't want to do that every time, but how would we know going forward if our patient had the right cuff pressure if we didn't do that? Well, at this point, measure it with the cuffulator, because now you know it's the right amount of air. And use that number going forward. So this is using this in conjunction with an MLT, just not going in and using it by itself. So let's say we did our MLT and we checked our cuff pressure and it was 24. Then my patient's cuff pressure should be at 24 going forward, because I know that's an accurate amount because I did it. Does that make sense? Okay. The last one is called the MOV, and that's minimal occluding volume. Minimal occluding volume is just like the MLT, except you don't pull back to do that little tiny squeak of a leak. Just listen over the trachea, pull all the air out, note how much is in your syringe, keep listening over the trachea, put the air back in until you don't hear leak anymore, see how much was necessary from an air-wise. So I put 4 cc's in, check the pressure with the manometer, and then use that pressure going forward. They're going to be pretty much exactly the same, whether you use either one. Proven in studies to give the best possible cuff pressure while still preventing VAP, because VAP is caused by those little secretions that are pooling above the cuff coming into our patient's lungs. So it's important not only because of tracheal wall erosion, but also to make sure that we don't let those secretions into the lungs to have proper cuff pressure. So it's been, as long as you do it that way, you will still have enough pressure to hopefully not cause damage, but still prevent VAP. The other thing they found is that, I was telling the group over there when I was telling them, is that there's a group, and I can't remember what it's called, but there's a group of hospitals that did a number of different studies because of the high incidence of ventilator-associated pneumonia over the years. You know, there's been a lot of different things implemented, and you're going to see that in clinic. Keeping the head of the bed up, all different things to try to prevent patients getting VAP because it increases their mortality. It's one of those things when patients get VAP, the hospital quits paying for it, all of that, because we gave it to them. If they get pneumonia while they're on a ventilator, it's because we gave it to them. So the idea is to do everything we can to prevent it. So there's a group of hospitals that did a lot of studies and actually have evidence-based data to show that this, along with other methods, is the best way to work on preventing VAP, and they have a 0 VAP percentage. They have no patients with VAP. The other thing that came out of that is while we do need to individualize our pressures, as a general rule, the minimum pressure on an adult patient should be at least 20, or you probably don't have it high enough. So,
What about
the end.
for pediatrics?
I don't know what their pressure should be, honestly, because I teach adults.
Minimal leak test.
Yeah, it's going to be lower. But the big population that gets VAP tends to be more adults anyways. So, all right. Okay, break.
Thank you.